that we're very lucky in the type 1 community. People who live with type 1 are very good at spreading the news between them. This is working for me. This is not working for me. So I think that organically, that's really where the fuel for the fire for TCR has really come. It's the type 1 community have said, this works for us. We need some help. Why aren't we getting it from our healthcare professionals?
So, welcome back to At the Helm, where we explore bold ideas in therapeutic nutrition, in metabolism, metabolic health, and better health in general. I am your host, Dr. Charles Helm. I'm broadcasting today from the traditional territory of the Treaty 8 First Nations in Saskatchewan in Canada. And today we are delving and diving into a very exciting topic, possibly a little bit potentially controversial, because we are talking today about type 1 diabetes and nutrition, not type 2, which is what we've been talking about in almost every other episode of this podcast series. So we're going to be talking about therapeutic carbohydrate reduction, which is TCR is the acronym for people living with type 1 diabetes. And we all know by now that low carb approaches have gained a lot of traction in type 2 diabetes and metabolic health, but up until now, the official clinical use of carbohydrate reduction in type 1 diabetes has been a bit of a gray area, but not no more, only until now. So joining me today, I'm delighted to welcome two of the five authors of a really groundbreaking new guide. And that guide is called Therapeutic Carbohydrate Reduction in Type 1 Diabetes, a guide for dietitians and nutritionists. It's evidence-based, it is very clear, it is very practical, and it is safe. And it basically guides healthcare professionals who want to support their patients who are suffering from type 1 diabetes in achieving more stable blood glucose levels through dietary means. My first guest is Beth McNally. She's a certified nutrition specialist. She's a licensed dietitian nutritionist. She's got a master's degree in nutrition and in integrative health. She's the founder of Type 1 Diabetes Nutrition, and she is a parent of a child with type 1 diabetes. So we know that Beth's insights today are going to be both professional and personal. She moved recently from Canada to Australia, where she now works in the Type 1 Diabetes Family Center. And also with me today is Amy Rush. Now, Amy is an accredited practicing dietitian. She's a credentialed diabetes educator. She's the clinical director at the Type 1 Diabetes Family Center in Perth, Western Australia. She is an award-winning researcher, a prominent clinician, all in terms of exploring how low carbohydrate strategies can safely support people with type 1 diabetes. And as we've said, Beth and Amy, along with three other co-authors, led the creation of this really important guide. They are in the forefront of reshaping the approach to nutrition and type 1 diabetes. Beth and Amy, welcome to At the Helm. I'm just so thrilled to have both of you here with me today.
Thank you. It's nice to be here.
Thank you.
Can we start right at the beginning? Your motivation. And either of you answer, just take turns, however you'd like to do it. But it strikes me there must be something of a gap that you and your co-authors perceived, something that motivated you to create this guide. You must be trying to fill some sort of a gap and bring things to the forefront. Any thoughts on that?
Yeah, sure. Amy actually was brought in before I was, so you might know a little bit more of the history. But my understanding is that it actually came from a registered dietitian and PhD researcher named Adele Height. And she had created the Therapeutic Carbohydrate Reduction Guidelines under the organization of the Society of Metabolic Health Practitioners in the United States. And they had done those low carbohydrate guidelines to help healthcare practitioners understand how they could support patients when patients wanted to implement them, regardless of the health history of the patient. So they were general guidelines, and they were a first major step towards helping clinicians be able to support patients in using a low carbohydrate nutrition therapy. And then after those guidelines had been developed, which was a multi-year process and had various experts involved in contributing to that project, Adele decided that she wanted to do condition-specific guidelines. And she decided to start with type 1 diabetes. And I remember being at a conference when she announced that down in the United States. And I remember being very surprised that they would start with type 1 diabetes, because it can be quite controversial because insulin therapy is involved, and you would have to make sure that if you ever decided to lower the carbohydrates, as Amy loves to say, titrate the carbohydrates, we also need to titrate insulin so that we make sure that the insulin for that meal matches what the person is eating. So it started with Adele Height, and she really wanted to make sure that we were able to have condition-specific guidelines for therapeutic carbohydrate reduction. And a group of volunteers were formed. Eventually, I asked for a seat at the table, having recently graduated with my master's degree. Amy was around that table, Francisco was around that table, Dr. Caroline Roberts, and Dr. Andrew Kutnick. And originally the group was larger, but it was really, really challenging to be able to take it to where we could be prescriptive with insulin therapy. There is no one set of guidelines for how you actually use insulin therapy for therapeutic carbohydrate reduction. So we decided to start with this guide and have it be oriented towards dietitians and nutritionists as a starting point, because dietitians and nutritionists are often the first healthcare professional that somebody sees when they decide to go this route. And it's really, I think it's useful for clinicians from many backgrounds. But that's sort of the evolution of this guide. And we actually had reviewers from all over the world. There were 11, I believe, international reviewers. And then the 5 authors were from Australia, Canada, and the United States. So it was an international effort. It was a voluntary effort. And you're right, Charles, we were trying to fulfill a gap because we found that people with type 1 diabetes were starting to come to their healthcare professionals in droves, saying they are already implementing this. And the healthcare practitioners did not know how to support them and weren't sure how to do this in a way that ensured that the patient was safe and well supported.
Wow. Yeah, I have a confession here. When in my medical practice, I've always, often felt that my patient with type 1 diabetes, just by virtue of living with the condition, knows a lot more about it than I do. And I almost feel intimidated sometimes. But at the same time, I know even with my type 2 patients with type 2 diabetes, if I listened carefully to them, they would teach me things. And I learned so much from them. And you're kind of reversing things because you get taught one way and then you realize, no, I'm not always telling my patients what to do. They're teaching me. And it's very exciting when you open yourself up to that sort of thing. But I can put myself in the position of those colleagues who have got patients with type 1 diabetes who are now coming and saying, I'm already doing this. What do you think of it? That must be quite threatening, I would imagine, to my colleagues. So, Amy, do you have any thoughts on all of that?
Yeah, you're definitely not alone there. And I think that this is a big part of why patients are out there doing TCR alone, because their health professionals just don't really understand type 1 diabetes, or are perhaps a little bit fearful of it for the reasons exactly what you just pointed out. These people are managing this every single day by themselves. And so we kind of feel a bit like, oh, well, you know more than I know. This is a new and scary area. So I think there's a lot of fear from a health professional standpoint around TCR because we don't know much about it. We've not been educated about it. And that's kind of where Beth and I come in that we want to change that.
Yes, absolutely. And so the guide is written officially for dietitians and nutritionists, but I would imagine my family physician colleagues, it's not that it's not intended for them. It's just they're not the first port of call. It's more about dietitians and nutritionists, but I would imagine it's open to everybody to absorb what's in it.
Yes, absolutely. And I think you raised such a good point. And, Charles, you're singing the same song that Amy and I are singing. And this is why I wanted to go and actually work with the Type 1 Diabetes Family Center in Australia. Because when we recognize that type 1 diabetes is not just a chronic condition, but it's incredibly unique as a medical condition. It's a full-time, pretty high-risk job for anyone who's been diagnosed with it. And it places the burden of care squarely on the shoulders of the person living with it. So I love that you say you're learning from your patients. And we understand why healthcare professionals can feel really intimidated. It's hard to understand how type 1 diabetes works if you don't live with it every day. And most of the people that are at the Type 1 Diabetes Family Center in Australia either live with diabetes themselves or have a family member who lives with it. So when we as a caregiver, I understand how it works because I had to manage it for my son when he grew up. So it makes it very different from most other medical conditions because it requires constant self-management. And so what we were hoping to do with the guide is we were saying, it actually is less scary to lower the carbs for people with type 1 diabetes because right away, once you have that diagnosis, your relationship with food already changes. And you start, now that we have CGMs, continuous glucose monitors, that actually know what blood sugars are doing 24 hours a day, 7 days a week, we can actually see the response to food. And so people are often changing their relationship with carbohydrate foods anyway, because they realize that, oh, wait, when I eat this, my blood glucose spikes a lot and I need a lot of insulin. And then I kind of end up being on this blood glucose roller coaster and it's really challenging. So people often naturally end up, titrating or scaling back the amount of carbohydrates they eat. And what we wanted to try to do with this guide, whether you're a dietitian or a nutritionist or a GP or an endocrinologist, we wanted to at least start having the conversation about what to think about when you are a healthcare professional and how you can support, the patients who come to you who want to do this.
Right. So I'm just really intrigued by this because I understand everything you're saying, but is this what's in your guide? Is this, and maybe you can help me with this, Amy, but what's in the guide is how does it differ from the general low carb therapeutic nutrition for our type 2 diabetic patients? I'd imagine there are some differences because if you've got type 1 diabetes, insulin is a must. It's a given, it's there. So maybe is there more titration and just less focus on low carb in general? But how does that work, if you can educate me?
I guess from a healthcare professional's perspective, there's kind of like three big hitters here. So insulin titration, of course, is a must. If we're eating less carbohydrate, obviously there's less rapid acting or bolus insulin being required. But overall and over time, there's also changes to the way that bolus insulin may need to be administered based on all macronutrients, protein and fat, not just carbohydrate. Again, over time, there's changes to basal insulin or background insulin that is required. So there is a real education piece around insulin adjustment, which I think is one of the scary parts for a healthcare professional because insulin is not just like a drug where we can say, right, just take 50 milligrams. Things aren't going well, let's increase it. Things are going well, let's decrease it. It changes in the moment every day based on actually 42 factors that we know of at this point. So it's not like we can just write a prescription for this is what you need to take. And that's one scary piece. I think the other ways it differs is that we know that with type 1 diabetes, hypoglycemia is a real issue, and ketoacidosis is a real issue as well. So there is a lot of questions around from health professionals who maybe don't understand the physiology and the background of TCR, that there was increased risk of these hypos and ketoacidosis. So I think that's where the issues are, the three big issues, I think.
Right. And that word ketoacidosis, that is the thing that engenders fear in us as family docs. And there's this horrible confusion between ketosis and ketoacidosis, which we get with the people with type 2 diabetes, and well, actually more even with my colleagues, because they hear the word ketosis and they jump to ketoacidosis
Yeah.
immediately. And it's a whole education thing to try and get around that. But I'm so happy you mentioned the CGM as well, the continuous glucose monitor, because I mean technology really has revolutionized things, and we just need to embrace it. And I even tell patients with pre-diabetes or just with insulin resistance, it's the best thing you can invest in it. If you've only got insulin resistance, you're not going to get it for free in Canada. You've got to pay for your 2 weeks, but it's the best investment you can possibly make, because then you're going to understand things. And if that's for folks with insulin resistance, how much more so for folks with type 1 diabetes? I mean, that's how I would see it. But can you just answer for me? I think you've made it clear this is not one size fits all. So it's as if there are some people for whom it might be more applicable, this carbohydrate reduction therapeutic TCR, and there are other people that it might not work as well for. Am I correct in thinking that?
Yeah, I think that's a great question. I think one of the things that all of the authors of this paper agreed to was, this is because type 1 diabetes really falls on the shoulders of the person living with it. And we have multiple tools in the diabetes toolkit: insulin therapy. What kind of insulin are you going to, choose? How is that going to be administered, by injection or by an insulin pump? What are the other things that we need to have in the toolkit? Well, we have nutrition therapy. And all of the authors were, trying to convey the message that people with type 1 diabetes can at least be made aware that this is one of the nutrition therapy options available to you. And I think a lot of healthcare professionals, particularly in the dietetics field, feel less certain about whether that should be brought up because guidelines don't exist. We have Diabetes Canada and the American Diabetes Association encouraging the use of, or mentioning that the use of therapeutic carbohydrate reduction can be beneficial for diabetes, but we don't have specific guidelines on how you would do that, which is why, we developed the guide. And so we wanted to ensure that every person with type 1 could at least be made aware of this, because as soon as you're diagnosed, if you are fortunate, to have some diabetes education, you start learning how to carbohydrate count. And, in my personal experience as a mother, I remember it was only maybe day 3, and we were measuring out the rice and counting the number of grams of carbohydrate in my son's, Mexican wrap. And we're trying to do all of this. And then we're trying to calculate what the insulin dose would be for the meal. And I mean, it's just so complicated right away. And then you have to decide, well, how many minutes before a meal is that, am I going to be able to match the insulin profile with when the food digests? I mean, it's just a completely crazy world from day one, as soon as diagnosis happens. And so you learn to carb count, but no one ever says, and by the way, you could think about lowering the carbohydrate, which may make it a little bit easier to manage blood glucose levels following the meal. And I remember, as being a mother, learning about low carb, therapeutic carbohydrate reduction, probably about a month and a half after diagnosis. And my husband and I just felt like we were really bad at managing diabetes. We just thought, well, why is this so difficult? Our son feels horrible all day long, his blood sugar swinging high and low and high. And then when we found out that, we happened to stumble on a YouTube video by a doctor in Australia named Dr. Troy Stapleton, who had been diagnosed with type 1 diabetes as an adult, and he had decided to implement a low carbohydrate diet to help with his diabetes management. And we just stumbled on this, my husband stumbled on this YouTube video, and we thought, what is this craziness? And then we thought, well, this can't be right, because why wouldn't the doctors tell us that this is an option? And, we then studied it for a month, and we went to our endocrinologist. And I have to tell you, she was amazing. This was back in 2015. And she said, I have never helped anybody do this. She was a fairly recent, she was fairly new in the endocrinology field. She was a pediatric endocrinology fellow. And she was so kind. And she was, straight up with us. She said, I have never helped anyone do this. Here are the things that, we need to think about. We need to lower the insulin. So we're going to have to do this carefully. And we don't actually know what will happen with the blood sugars. And everyone who has type 1 diabetes knows everything you do is trial and error, whether it's exercise or eat a food or, everything you have to do, you learn through lived experience. But because she was so supportive, my husband and I were so appreciative that she was just able to sit down with us. And we sort of had this half-an-hour meeting where we both went, we don't really know what we're doing here, but we're willing to try something new. And we want to do it in the safest way possible so that our son, doesn't have a hypoglycemic moment. So that's, that made all the difference in the world to us. And so when this opportunity came for us to produce this guide, we want healthcare providers, they don't have to have all the answers. They can ask the great questions that you're asking your patients, because people with type 1, they know their bodies, but they just need some guidance around how can I use insulin when making dietary changes.
Yes, I think what you're sort of angling at here is that every patient with type 1 diabetes needs to know, has the right to know that this is an option. They don't have to choose it, but they need to know that it's there. And so, one's hope is that within a few years, it's just the standard of care. And if you don't inform your patient of that, then you're almost being negligent, because why aren't you doing it? Because I find it so ironic, Beth, that you picked this up through a YouTube video. On the other hand, it's just so refreshing to find that you had such a sympathetic endocrinologist who was willing to walk through this whole pathway with you. But
if
Amy,
I can just add to
sure.
that one,
Yeah,
your question at the start around, is there anyone who this is not appropriate for? And I often get asked this, and I take it back to there's this, I think, again, misconception that there is a low carb amount. So if you're going to be low carb, it has to be this much carbohydrate per day. And I always say to healthcare professionals, your low carb is your low carb. So if you were currently eating 300 grams of carbohydrate per day and you decided you were going to decrease to 150 grams per day, that is your level of low carb. And that is going to have a really big impact on your insulin requirements and lots of other things. So I don't think there's anyone who it's not for. Perhaps there are groups of people who may need to have a higher level of carbohydrate, but everyone with type 1 would benefit from lowering their carbohydrate to some extent if they had the education around how to titrate their insulin alongside that.
Right. Can you help my colleagues here? Because when I hear what you're saying, and it sounds so exciting and so logical, I must add. It's just, why didn't I think of this stuff 20 years ago? But I also think, geez, I don't want to do any more harm than good. I want to be careful. I don't want to see hypoglycemia. I don't want to see ketoacidosis. And, it can be scary. And here I am trying to manage type 1 diabetes for my patient. I'm just safety conscious, and I'm aware of, maybe to the point of not being bold enough, but what are the protocols? What are the safeguards that you have? Or is it just, if you do it properly, it's not going to happen? I'm just safety conscious. So what do you think of that?
Can we do like a little Q&A, Amy? I love this. Dr. Helm,
We do this all the time.
yeah, you feel nervous. You don't
Yes.
want your patients to have a hypo. You're not sure how to introduce it. So what's one question you have? And we'll answer it.
Well, no, sure. So, I mean, my first thing would be, I think, to make sure that it's the patient, when I broach the topic, that it's a suitable patient. So it's someone who has a good interest in their health and really wants, isn't in that phase where they're angry and unstable. I don't, I just don't feel it's the right thing maybe to be introducing at that point. But once things have settled down and the person accepts I've got this for the rest of my life, I've got to work out how best to do it, then it's just, I think what it will boil down to is finding a way to explain. I love that analogy you've got in the first part of the guide where you talk about it's an engineered system and these are inputs into the system. Insulin is an input. The amount of carbs you eat is an input. And these are both a bit unstable. And so if you work on these two things, then we can stabilize blood glucose levels in general and get by with less insulin. But that whole thing is a bit of a complex
Mm.
concept. And so what I'm interested in is what tools you have, just if you were explaining this to a suitable patient, let's say we've got someone that we think is suitable, how are you going to explain that? And how do you present your rationale? So, because I'm imagining for the patient to want to do this, that they have to understand what you're saying and why this is a good idea. So, and if we fail in explaining that, we're not going to have a successful outcome, or they're just not going to be interested. So how do you get that message through?
Yeah, that's a great question. So I would love to just start with for a couple of sentences, and then I want to pass it over to you, Amy, if you don't mind. So the first thing I would say is even the way I see you thinking this through shows how complex this is for a healthcare provider. You're actually trying to figure out, well, how can I tell people who are the patients that it would benefit from? I mean, there's a lot to think about. And this is the exact work that Amy and I are currently doing at the Type 1 Diabetes Family Center. We're producing materials and we're trying to create ways so that people don't feel that it's so hard and all the burden is on them as a healthcare provider, while at the same time making sure that patients who want to do this have support and patients who may not know about it can find out about it. So we definitely need those resources, and those are currently in the works. I think it would be helpful. I love the way that Amy starts when she starts working with people, the way you've explained it to me, Amy, when somebody first comes to you, or how you decide that you want to talk about it. Would you mind sharing with Dr. Helm what you do in your practice?
Yeah, yep. And I'm trying to think about what we've talked about, where I should start. So I think the most important thing when someone first comes into my office and says, I've heard about this low carb thing, do you think I should do it? And that's normally what they will say to me. I think it's important to find out their motivation behind it. Is their motivation that their blood sugars are just all over the place and they're swinging between high and low, they feel awful, they're exhausted? Is their motivation because they've just had enough of the mental maths? They just don't want to think about so many numbers. They don't want to think about having to correct and treat hypos and those kind of things. Are they suffering from significant hypoglycemia and they think that, well, this is a way to reduce my insulin? Is that a good option? So finding out what their motivation is first. And then I think it's really important that they understand that relationship between their insulin and carbohydrate, because although people with type 1 are doing these titrations every day, so many of them don't actually understand how the insulin works and in relation to how the carbohydrate is digested, let alone when we start talking about protein and fat and things like that. So it's really good for them to have a foundation of how does insulin work? How does carbohydrate work? And if I am to adjust my carbohydrate intake and reduce it, how do I then reduce my insulin around that? And then link that to their main issue and explain, well, how is this going to benefit you if you're currently all over the place? Well, we're going to decrease that risk of significant postprandial hyperglycemia, which then requires a correction dose, which then often lands in a hypo. If they're suffering from significant hypoglycemia, we are going to reduce that bolus insulin across the board and help them feel more confident to do anything every day. Is that where you were going with that, Beth? Does that explain that?
Yeah, I think it's great. And I think the fact that we start with asking the person, like, so for example, Dr. Helm, by simply asking your patient, like, what are you currently struggling with, right? Because it's hard for you to know, is this what I should be talking about? I think everybody has the right to do it, and we need information within, medical practices to be able to introduce it in a way that they can take it home and read it and think about it. But we also need somewhere for them to go, because GPs don't have time to do all of this. This is the work of the certified diabetes educator in Australia called credentialed diabetes educator, or CDCES in the US. And, this is the kind of thing, that we're actually, I feel like the guide is step one. And the work that we have been continuing on with is, okay, we are now developing resources for healthcare providers to be able to use in their practice. But really, the information that you currently have on low carbohydrate nutrition, therapeutic carbohydrate reduction for type 2, everything works the same in terms of the food. We just have to be very cautious with the insulin. And I think, Amy, what I should have communicated this in a better way. Oftentimes when you work on insulin therapy, you sometimes have to say, we don't really know what will happen. So we actually have to do almost no insulin and then see what happens after we eat the meal. And then, the credentialed diabetes educators can work with the patient and helping them learn how to, what we call, self-adjust or self-titrate. And so then, because speaking as a caregiver, it's way easier than healthcare providers realize. We know how, in my case, my son's body works, right? So I just need to understand how the insulins work. I need you to help me to understand what will happen if I give too much insulin so that I keep him in a safe place. And so it's really important, I think, for us to have resources for healthcare providers, but also to have somewhere for people to go. And I think that's the challenge that GPs face, where they say, I can introduce this, but now where does the diabetes education fit in? And that's one of the things that we're trying to work on in the Type 1 Diabetes Family Center in Western Australia. And, we are developing, programs and services so that people all around the world will be able to refer to us, because Type 1 diabetes is a specialized form of diabetes, and you have to really understand how it works and how it's so much different, than Type 2 diabetes and the other forms of diabetes. So we understand the challenges that you face, but it's not as scary for the person with type 1.
Yeah. So, Amy, I'm going to ask you just a question about how fulfilling it must be when this goes well, and you've had good input and your patient has taken it in, and they start doing it, and I've got this idealized notion here of maybe it's utopian, but then they come back to you and they say, this is great. I'm on less insulin and I'm not eating as many carbs and I'm feeling great. Does this happen? Are there cases you can give me where you just have that amazing yes moment, eureka, I've done it, it's worked? Does that happen?
Absolutely. The number of CGM graphs that I get emailed back to me in the first week post implementation of TCR, they'll send emails with these flat lines. I've never seen this before. It's incredible. So exciting. And then the next week you'll get another one that's more about, I don't have to think so much. Like, I feel like I've just got this free space in my brain all the time. And I think I've told you this, Beth. I actually had a lady in my office once who just broke down into tears. And she said, I all of a sudden have this so much free space. It's like this loneliness now. I'm not thinking constantly about numbers and what I have to do next and what has just happened. And so she actually felt quite lonely. So it's like this two-pronged. It's like this, oh my gosh, my CGM scorecard, which we call it, I'm getting, 100%, ticks all across the board. But then this impact on their mental health as well, this freedom, and this feeling of safety when your blood sugars aren't doing this all day long and you're smashing massive doses of insulin constantly. You feel safer in everyday life, but you feel safer to do things like exercise or take that ad hoc walk with the dog after dinner because you haven't got 15 units of rapid acting insulin floating around in your body.
Yeah.
So yes, we do get those a lot.
Yeah.
That's
and
amazing.
I'm not so I actually met this morning with a 13-year-old and his mom, and she said, our gift this weekend using therapeutic carbohydrate reduction. So, when you lower the carbs, you have to up the protein and the fat. And they said we opened our pool and our 13-year-old with type 1 swam for 3 hours straight. We did not have to correct a hypo. We did. So what did they do? And I said, okay, so tell me what you did, because the hardest part of type 1, it's not just the food, it's everything. There's so many things that affect blood sugar levels. So when you go to exercise, sometimes your blood sugar goes up, sometimes it goes down. It's so frustrating. You can't get on with daily life. So this morning they said the family swam for 3 hours, and the mom actually said, we forgot that type 1 diabetes was even part of our life. And what happened was they ate a low carb, high protein, high fat meal just before swimming. And they actually, in this case, didn't dose any insulin for it because they knew he was going to be very active swimming right after. And if you have a lot of insulin or some insulin in your body just before you do an exercise like swimming, often you can have a hypoglycemic moment. So everybody has to stop what they're doing. And, the child has to sit down and sit out of the pool, and you get the glucose out. And so there's all these things that have to happen. So 3 hours of a family, and she actually, the mother kind of started tearing up. She goes, it was Mother's Day. And for 3 hours, we swam in our pool and nobody thought about type 1. For 3
That's
hours.
amazing. I mean, these are the reasons why, why I became a family doc, why you folks pursue the careers you do. I'm sure it's for those, many, many reasons. But one of the things is when you have those moments, it is just so precious and fulfilling. But Beth, do you mind if I personalize this a little bit? You've spoken very eloquently about the clinical aspect of things, but you have a son with type 1 diabetes. So how this affects you, from a personal perspective, you've got insights from so many different perspectives here. But how has that affected you in terms of your work, in terms of your life, and etc.?
Yeah, well, it certainly informs the work I do now, because obviously had my son's name is Lachlan, had Lachlan not been diagnosed, I wouldn't, I didn't know a thing about type 1 diabetes before he was diagnosed.
Okay.
And I think my curiosity led me to go back to school, because we started, it's not, you can't just do therapeutic carbohydrate reduction. You need to understand how to use insulins appropriately. You need to understand how to correct a low and a high blood sugar, etc. But the food becomes a big part of what makes it easier to manage diabetes. And I decided to go back to school, because even though we had been able to normalize it, like when he went low carb, he went to like a 5.0 A1C. Like I had no idea that it would be that big of a difference. And so I went back to school because I said, I don't understand what's happening in the body. I am an art, public policy master student. I don't know how the body works. And so that's sort of how it led me sort of down this path. And when I graduated, I didn't think I'd work in the type 1 space, but there just seems to be a huge gap, especially in the pediatric space. And I find a lot of people think that kids need carbs to grow, which is not true, as long as they have enough food to eat, regardless of whether it's a carbohydrate or, they really need a lot of protein. And so I just sort of have really enjoyed working with other families in this space. And my son keeps teaching me, he's now 19. He left for university 2 months ago. That's been a kind of a whole other phase of life as he manages independently. And so I think that's helps me relate to those parents. And, it's still not easy every day. Like we don't have like perfect blood sugars at all. And as my son figures this out, it's hard to sometimes watch as a mother to go, oh gosh, what's he doing today? Why does his blood sugar, and why is it, fluctuating like that? but it just feels great to be able to work with people to say, if you're willing to change the food, there can be a lot more peace of mind, not only in the moment, but in the future. And so that's sort of, that's how I sort of came into the space. And I must admit, I love working with people who have some lived experience with type 1, because you just kind of speak the same language. And this is why I'm also trying to help translate it, and why Amy blows my mind, because she has worked with so many people with type 1 for so many years that she can see, she can look at a CGM and be like, this is what's happening with their blood glucose levels. But it's just lovely for people to have a soft place to land, because oftentimes, we had a great endocrinologist, but we've also had endocrinologists that told us to stop, and did not support what we were doing. And that's incredibly challenging. And it's very hard if you can't find the support you need. So I guess in some ways, this was a passion project for me personally, because for years, I kept hearing, we want to do this, and our doctor says we're not allowed.
Yeah. Yeah, no, we encounter that with type 2 diabetes as well. And, that's the challenge, is to get the message out and to scale things up so that more and more people understand this. But I know that in my small remote community in northeastern British Columbia, for the longest time, our diabetes educator actually had type 1 diabetes herself. And she had no problem with me when I did the referrals. I would say, she's actually got type 1 diabetes. She really knows what she's talking about. And somehow, I know that created a bond for my patients, just knowing that here's someone it's not book learning. This is lived experience this person has got. But Amy, may I ask you, I think Beth has maybe touched on it, that maybe there are some clinicians, some endocrinologists, some physicians who are not jumping on board here. But has the majority of the reaction been supportive? Has there been skepticism? Has there been pushback? Has it landed well, or can you summarize that? Yeah, is this, in other words, is there still a controversy, or is it just, no, this is the way we're going to go now?
Well, back in, it would have been about 2016, 17, when I first started basically looking at low carb as an option, and kind of like, I think you suggested it earlier, like, why didn't I think of this before? It just makes so much sense. And started talking about it with patients and started talking about it with other healthcare professionals. And this was at the time where it was really controversial. And down here, there was no one on board. I came up against my governing bodies. I was probably lucky I didn't lose my license at one point. I think it was just because I was over here in Perth and everyone was like, just leave her over there, let her do her thing. Over the years, it has become obviously much more widely accepted. There's more clinical research. We've been doing presenting at conferences and things like that. So I'm not going to say it's widely accepted, but people are much more open to discussing it and learning about it. I feel like we're kind of stuck there, though. They'll listen, they'll learn, but they won't help. They won't help a patient implement it. And I think that is just all around this fear base that is just bred from a lack of knowledge. There is no education for healthcare professionals on how to help somebody implement TCR in type 1 diabetes.
It's not where you're at, it's where you're headed. So what I'm hearing from you, I know you used the word stuck, but in general, your trajectory would seem to be moving towards greater acceptance and less controversy. And that's really encouraging, because this is so logical. I just have to say that. Why didn't I think of it? Yeah. But so the uptake to the guide specifically, I've heard that there are even translations pending into different languages, which is obviously an incredibly good sign. How's that going?
Yeah, it's going well. So it's being translated to French at the moment, and we're hoping that will be done by the end of this year, and also into Norwegian and Italian There have been a couple of other languages, Spanish and Portuguese, that people have asked about, but the translation work is currently happening. It's a little slow going because this is completely a volunteer project. So people have their full-time clinical jobs. Every single person doing the translation is a clinician involved in helping people with type 1, or they are a clinician and they have type 1. And we also have tried to build in a clinical review process even for the translations, for some of the translations, because we want to ensure, some of the language we're using is new. So we want to ensure that people understand what we mean when we are translating it from, for example, English to French. We've worked a lot on that in Canada, obviously, because we have 2 official languages here. So we want to ensure the French is released, but we need to make sure that it makes sense to French-speaking clinicians. And we have people from both France, and Canada on those as part of our translation committee.
Right. But so where are we? The translation is one thing, but I'm thinking, are we headed towards new clinical guidelines? Is there a need for more research? Is it ethical, if we know this works so well, even to think about doing clinical trials? How do you do clinical trials when someone is pretty clear on what they're eating? It's hard to imagine a kind of a double-blind situation with this, but maybe clinical guidelines is the way to go. Wouldn't that be a dream for you, that number one of the clinical guidelines is what you're talking about?
Yeah, well, I mean, we would love for the larger diabetes organizations to fully embrace this and to be able to, look at this more closely and just to continue to give the nod. So, earlier this year, the Society of Metabolic Health Practitioners put out a position statement, and those doctors and clinicians encouraged other, their counterparts to, embrace the option of having this nutrition therapy available in type 1 diabetes specifically. So we have more and more people signing on. I have heard from a lot of the families that I work with, even 2 to 3 years ago, the doctors would say, you can't do that. Now, a lot of the doctors are saying, I will support you, but I'm not sure how. And so we need to be able to have training available, and we need to be able to have resources available. And, that's what we have been working on in order to, be able to help people feel confident that they can support people with type 1.
So, as you folks may know, I am with IPTN, the Institute for Personalized Therapeutic Nutrition. And I know IPTN has been supportive or involved in this process. So, Beth, I know that you are, or at least recently were in Canada, so obviously very familiar with IPTN. And I'm just wondering if you can help me understand IPTN's role in all of this.
Yes, thank you. This guide would not be possible without the Institute of Personalized Therapeutic Nutrition, who I think most people know that IPTN is based in British Columbia, Canada, but it really has been an international organization. And Sean McKelvey, who's the CEO of IPTN, was at the table from the very beginning when Adele Height had this original idea. He's one of the people that have stayed through the whole process and kept pushing us to make this happen. And to be honest, in the early days when our group was becoming really kind of quite big and funding was not available to support the project, it was Sean that would have long conversations with me saying, we really need this guide. We really need to support people with type 1. And if we don't write it, who will? And, that made me go, well, I'm not really exactly sure the best way to pull this off, but we have amazing people around the table from endocrinology, dietetics, research, and diabetes education backgrounds. So we really need to pull it together, but it was really IPTN that was a driving force behind everything happening from an administrative perspective. And also they were the ones who funded the publication of the guide, which, really helped us sort of get it over the line. So Sean McKelvey is CEO, and Anne Mullins is a senior editor at IPTN. And I know this sounds crazy, but when you're in a volunteer project and you have a team behind you, it actually feels like, the 5 co-authors could actually birth this project and get it out into the world. So we really are very thankful.
That is so encouraging. I'm so proud to be a part of IPTN when I hear that sort of thing. But that just sounds like what Sean does and the way and what Anne does and the way things work. So, um, and I know that the guide is on the IPTN website as well, prominently displayed, because it's such an important guide. Wow, that is wonderful. Um, Amy, I want to ask you a question about scaling up because it just seems to be when we talk about this, it's so exciting. It is wonderful. It is one gets enthusiastic just being in your company, but there seem to be so many people who have not heard this yet, and it is difficult to get to everybody and to have them informed, well informed, and not just well informed, but confident enough. And even amongst dietitians and nutritionists, how to get that message through there. Because we have folks that really, I guess, in any profession, folks that love grabbing the new and being on top of things, and others who feel more comfortable with what they've been taught 5, 10, 20 years ago. How do we scale this up so that in a couple of years, everybody knows this and everybody is talking about it and it becomes the new norm? Because that's what I'd like to see anyway.
I think that we're very lucky in the type 1 community that people who live with type 1 are very good at spreading the news between them. This is working for me. This is not working for me. So I think that organically, that's really where the fuel for the fire for TCR has really come. It's the type 1 community have said, this works for us. We need some help. Why aren't we getting it from our healthcare professionals? And that's really where Beth and I come in, and where we are really looking to go in our future is to be that kind of connection between the community and the healthcare professionals. The community wants to do it. Well, the healthcare professionals would, I predict very much so, be on board if they understood what their role was and how to do it. So having that education piece, hopefully that is what will finally click for everybody. If we know what we're doing, we're more confident to go out there and support it.
Yeah. Yeah, and I love it when I hear that a group of patients is actually taking the lead. It's wonderful, and we learn lessons from them. But so in wrapping up here, I just want to ask each of you a final question. It's the same question, but I'm imagining there will be some viewers, some listeners who actually suffer from type 1 diabetes or have a loved one or a family member that they're caring for, or just a friend that's got type 1 diabetes. So your ultimate take-home message, what is the thing that you would like those folks to take from our conversation today? Beth, can I go to you first?
Yeah, sure. I think it's always helpful to learn that nutrition plays a huge role in type 1 diabetes, because the factor that has the greatest impact on glycemia and the one you have the most control over is the food which you consume. And so if you can learn about therapeutic carbohydrate reduction, you will start to understand that the foods you choose can make, type 1 diabetes easier to manage. Because when you eat foods that have less impact on glucose, there is a positive flow-on effect. You have a reduced need for insulin and so forth. So I think the first thing that I would do is I would go to the IPTN website. I would download the guide. If you're in Australia, we also have the guide on the Type 1 Diabetes Family Center, because they did partner with IPTN on putting it out there in the different countries, making this publication available, and start asking questions, in relation to nutrition therapy. It can be a very isolating condition. Like sometimes the people that you live with in your own house don't even understand the burden that type 1 diabetes management places on you every day. And so when you surround yourself with a community that understands you, and you can get support from other people within that community, it can make all the difference in the world. So I would say find your tribe, as we say, and also consider how nutrition therapy could make diabetes easier to manage and reduce your risk of complications in the long term.
Right. That's very inspiring. Thank you. Thank you. Amy, you've had the benefit of some time to think about the question.
Well, look, the find your tribe was definitely something that I was going to echo. So maybe going further to that, is yes, find your tribe, because it is a very lonely and isolating disease. And I think that it's not just that, it's that no two people manage the same. It's not just a set and forget. Every single person is different. So when you start talking to other people, you really start to question yourself as a person with type 1. Am I doing this right or am I not? Because you will manage so differently to everybody else. So yes, finding your tribe is really important, which is something that for us here at the Family Centre is like right up there. As soon as someone's diagnosed, that's the first thing we do is pull them in. But the next step, I think, is finding your healthcare professional team. So when you're first diagnosed here in Australia, you are sent to the hospital and you have regular follow-up appointments, maybe 3 monthly. You are seeing different healthcare professionals all the time. They don't know you. They've got 15 minutes with you. It can feel like, I mean, all they've got time really to do is look at your CGM graph and tell you whether you're doing good or bad. That's basically it. And that can feel, again, really isolating. You feel like you're doing everything wrong. So find that group of healthcare professionals that you click with and that can support you and that can follow you through and be that really core support and will be open to when you come in and say, I want to start an insulin pump. I want to trial TCR. So finding your tribe in the community, but finding your tribe of healthcare professionals as well.
Yeah, what both of you have really, I think, are saying, if I can paraphrase it, it's how intimidating, how overwhelming, how isolating this diagnosis can be, but at the same time, what we really need is things that empower our patients. And what you're talking about here is absolutely empowering people. Here's something, yes, I've still got to take my insulin, sure, but here's something I can control and which can make me do better. And it's within my control. It's not just this medication that my doctor is prescribing for me and I go to the pharmacy with a prescription. This is something that I can do. And to me, that is huge. I just want to thank you for all your work in bringing that to the forefront. From my side, every now and then you think, okay, I'm understanding a bit more about, maybe I know a bit what I'm talking about now, and then I talk to folks like you, and I realize, nope, I've got to start again and go back to square one and relearn. But the beauty of this is not going back and relearning something or learning something for the first time that is foreign. This is just so darn logical. And it just makes such perfect sense. So you have me enthused, I can say that. And I just want to thank both of you. Here I am in Canada, you're both in Australia, but it's amazing what Zoom can do these days. And just really, really appreciate the time that you've taken to spend with me on At the Helm today. It's been an absolute joy and a privilege speaking to both of you. I wish you both the best of luck, and I hope that your trajectory continues to go in the right direction. Obviously, I want to thank IPTN for sponsoring this podcast series. I want to thank Anne Mullins, our producer. I want to thank Graham Wheeler, our technical guru, and RCC, the Rural Coordination Centre of BC, for inspiring me to do this work. But once again, Beth McNally and Amy Rush, thank you so much for joining me today. And I hope to see everybody again on At the Helm soon. Thank you.
Thank
Thank
you.
you.